kind invitation to be here. I think this is fun. I think it's a nice way to do education, to discuss cases in real time. I mean, just so the audience knows, I haven't seen the cases, and it really helps to discuss how we work up a case based upon the morphologic appearances and what stains or molecular tests might be helpful. And if I make a fool of myself and get the diagnoses wrong, I don't care really, because I'm getting old, so it's fine. So anyway, I'm glad to be here, Cleo, and please go ahead and start. You're mute now. Cleo, you're still mute.
Cleo? No et sentim.
Cleo? We don't hear you.
Yeah.
Ahora.
Okay, sorry. The case I'm presenting today is the case of a 46-year-old woman who presented an inguinal mass of 8.5 per 6 per 6 centimeters, more or less, on palpation, and she was diagnosed in a peripheral hospital by a surgeon, and he oriented the case as an incarcerated inguinal hernia. They decided to go to surgery, and once they entered, they found a big mass, and they decided to do an incisional biopsy and send it to pathology. These are the images we will see. And after that, they perform an MRI to the patient, and this is the image. You can see the big heterogeneous mass, low-lated, and with these peripheral nodules surrounding the mass in the inguinal region. Okay. Histologically, the tumor presented. Do you want me to show all the H&Es?
Sure, you do whatever you like.
Okay, so I will show all the H&Es and I will give you time. Most of the tumor had a myxoid background or a more collagenous, slightly sclerotic background. And the cells were organized mainly in cords, strands, trabecular pattern, or small nests in this matrix-rich in this collagen-rich or myxoid-rich matrix. And you can see in these images now, I will show you different images of the different patterns we can see in the tumor. In some areas, we have more collagenized stroma with this cordonal sometimes, or these cohesive cells in more myxoid areas. In this area, this is more collagenous, also quite cordonal or trabecular. Other areas were more solid, but with mucin cyst or myxoid matrix cystification. And there were white solid areas like this with some discohesive aspect of the cells, but quite solid, and with also some lymphocytic infiltrate. In the periphery of the lesion, we can see how the lesion was infiltrating the skeletal muscle. And there were also areas of necrosis, clear necrosis. And here you can see also this pattern like trabecular, reticular in part, and with this mucin cyst. And the cells, when we saw them closer, showed this slightly big nucleus, not big, but vesicular nucleus with a prominent nucleoli, and a scant cytoplasm that was sometimes more eosinophilic and sometimes slightly more amphophilic. These images are at the same magnification, and you can see that in the areas where the tumor was less cellular, the nuclei were slightly smaller than in more cellular areas. Okay, and I think the next one is, yeah. So you can give us your opinion, Chris, please.
So, I mean, what you described very nicely is essentially a poorly differentiated epithelioid malignant neoplasm. And you kept alluding to the growth patterns, the trabecular growth pattern and the nests and the myxoid matrix. So you would think first of a myoepithelial lesion, and with that nuclear morphology and prominent nucleoli, that would have to be myoepithelial carcinoma. You might also think maybe about a proximal type epithelioid sarcoma, but it would be unusual to have such a prominent myxoid matrix in that context.
Okay.
Those are probably the two main differential diagnoses I would think of.
Okay, that was the same problem. Also, the same differential for me. I include other entities in a more theoretical consideration, but mainly our differential was between epithelial carcinoma and proximal type epithelial sarcoma. Also, because I have very few experience, I consider the more solid variant of the extraskeletal myxoid chondrosarcoma. And ossifying myxoid tumor, I put it here because of a theoretical question, but not because really I thought it was it. So then immunohistochemically, the lesion showed, in most of the lesion, we found multifocal or slightly patchy EMA positivity, multifocal pancytokeratin positivity, very, very few scattered cells that look like really tumoral cells. So because it's sometimes difficult to be sure that they are not histiocytes or dendritic cells, but I was convinced in some of them, and negativity for GFAP. But in the less cellular areas where the cells were smaller, the EMA was more diffuse, also the pancytokeratin, and we found more strongly positive positivity for S100 and GFAP in cells that were clearly tumoral, but was focal, was not really something diffuse. We also found in these less cellular areas some calponine, some P63, and I1 was lost. Do you want to do any comments on that?
No, I mean, that's perfect. I mean, you couldn't have asked for more clear results proving that it's a myoepithelial carcinoma.
Okay. Yeah, that was my diagnosis. In this case, SOX10 was focally, very focally, CD34 was negative, and we performed EWS rearrangement by FISH and was also negative. This was our diagnostic, and in this case, I was quite convinced. We can go. I had two slides to explain to the audience what myoepithelial carcinomas are. Do you want to explain us something, or you prefer me to?
No, the only comment I would say, just based on what you just showed us, is that the EWSR1 rearrangements, while they're quite common in myoepithelial tumors, it's much commoner for the gene fusions to occur in younger patients, especially pediatric in the myoepithelial carcinomas. It's not so common in the myoepithelial carcinomas in older adults.
Yeah. Are you talking about EWS or INI1?
EWSR1.
It's more frequent in pediatric.
Yeah.
Okay. Okay, thank you. As probably all of you know, these tumors develop more frequent in limbs or limb garlands, especially in the subcutaneous, but also can develop deeper or in the viscera. The age of presentation is wide, but most of them are developed in middle-aged adults. These are typically well circumscribed and nodular tumors, but sometimes can be infiltrative, and this has no, apparently, according to the literature, it has no prognostic significance. And typically, these are heterogeneous tumors, matrix-rich tumors, especially with chondromyxoid, myxoid, or hyalinized areas. The cells usually are epithelioid or plasmocytoid or rhabdoid, but also can be spindle and is slightly frequent, and can show metaplastic cartilage or bone. In my knowledge, but please say something if you consider it is needed. The hallmark by immuno would be the co-expression of cytokeratins or AMA and S100 or GFAP. but also they can have other positivities like calpain, SM-actin, desmin, P63, or also SOX10, but more in the more benign lesions. And in I1 is lost in around 40% of cases, but it's more frequent also in pediatric. This is true?
Yeah.
These tumors also can show AWS R1 rearrangements with different partners. These are the most known ones, and BEND1 is one we detected in one case in our hospital that has not been published. I don't think it has more importance, but since we have it, I put it. And also they can have PLAG1 rearrangements. And the criteria for malignancy in these tumors is something that at the time I was worried about, because I thought it was not very clearly determined. But since I have learned to detect these cases and I have more experience, it's really easy, because it's mainly because of atypia, and the atypia is mainly due to a prominent nucleoli and an alteration of nuclear cytoplasmic ratio. In our experience, pleomorphism have to be taken with caution, because some clearly benign lesions with a benign behavior have some focal pleomorphism. I don't know if you have the same experience.
Yeah, I mean, I think when they're very frankly atypical and they look like as if it was metastatic carcinoma from somewhere else, then it's easy to recognize as malignant. But if it's otherwise uniform with just kind of focal pleomorphism, then that would not be enough.
Okay.
To look malignant.
These lesions also can have necrosis, and the mitotic activity can be high when they are carcinomas, but not always. So the main criteria is atypia, isn't it?
Yes, absolutely.
Thank you. And the prognosis is quite poor in the carcinomas, not in the benign counterpart, with a 35 to 40% of local recurrence, 40% of metastatic rate, and they have a pattern of metastasis that is slightly different to the big majority of sarcomas, because it tends to go to lymph nodes. And when the location is deeper or visceral, the prognosis is poor. Radiotherapy has a role helping to control local disease, but chemotherapy is still undetermined. However, there are some knowledge and some recommendations at the moment. Our patient was diagnosed 1 month more or less after this first surgery that was unexpected, that was unexpected tumor. And then after the diagnosis, he was operated, and he received adjuvant radiotherapy, because as you can see, the margins were very close to the tumor. And in the prognosis of this patient was absolutely poor, with metastasis in lymph nodes, lung and bone at 5 months from the presentation. She was treated with carboplatin plus Taxel, that is one of the chemotherapeutic treatments that seems to be slightly better for these tumors. But anyway, she died 30 months after the first surgery. So the prognosis was very, very poor. And now I have another tumor that we received 2 weeks. It will be short, okay? But it's very related. We received this other case 2 weeks after the neoepithelial carcinoma. It was a mass in the femoral biceps of a 33-year-old man. And as you can see, it's a very lobulated tumor with very highly cellular areas, but as this magnification, we can we can see some myxoid areas or focus. It was slightly heterogenic, but not as the other one. The cells had more prominent cytoplasm. The nuclei were very similar to the other lesion, with more eosinophilic cytoplasms. In some areas, clearly rhabdoid with this kind of eosinophilic droplets. and some myxoid areas, but much less than in the other lesion, and in some areas having this nested architecture. Okay. Do you want to say something? No?
No, I mean, we obviously with those rhabdoid inclusions, you'd wonder maybe about proximal type epithelioid sarcoma. That would be uncommon in myopithelial carcinoma. And
yeah, I think morphologically for me was the same. My first the diagnostic was epithelioid sarcoma, and the second one, and because I had the other case a few weeks before, and it's not a frequent diagnostic, so I consider that, and I did all the immuno. So the EMA was more diffuse than in the other case. CD34 was negative, that can be in the proximal type epithelioid sarcoma. INI1 was also lost, and my S100 was negative. And the problem comes with this GFAP that was quite diffuse. So it was weak and slightly paranuclear sometimes, but it was around the lesion. So is it enough to change the diagnostic to a myopithelial carcinoma? Can we consider that this can be a higher grade of a myopithelial carcinoma, or we have to stay in a epithelioid sarcoma? Sorry, I'm not sure if I'm saying the correct thing. Yeah, is that enough for a myopithelial carcinoma, or we have to avoid this and consider a epithelioid sarcoma?
Well, I suppose I would want to do S100 and SOX10 and P63 and other things that might help support myopithelial. If they were all negative and there was only very, very little weak GFAP, I would probably ignore the GFAP.
Okay, so everything was negative, so we would consider that as an epithelioid sarcoma. And my last question for you is all these lesions that are losing IN, I1, and have some similarities, most of them. So some of them are more specific, but myopithelial carcinoma can be very similar to extraskeletal myxoid chondrosarcoma, and a subgroup of them can lose IN, I1. Epithelioid sarcoma in a different spectrum, different types of myopithelial carcinoma can look like this or like this, or like a chordoma, or like a extra. Sometimes I think it's very difficult to differentiate between them, and especially because in my experience, immunohistochemical markers for myopithelial carcinoma usually are not really diffuse and strong, but are focal or multifocal, or in one area and the rest is very negative. And if you haven't done the immune in the proper place, you can lose it. It's just to know your opinion and how to manage with that.
No, I think it's true. I think in some cases it really is very, very difficult, and to make the distinction. And the examples of extraskeletal myxoid chondrosarcoma that show INI1 loss, in our experience, usually don't have the NR4A3 gene rearrangement, so it's harder to prove. I mean, in the end, so much of what we do comes back to morphology, yes, because the immuno there's often so much overlapping. The poorly differentiated chordoma is easier because you'd expect brachyury, which would not be present in any of the other things.
Yeah, they have described this tumor now that I'm not sure if this will stay on our classification of tumors.
Yeah.
This is showing brachyury positivity. So for me, it's crazy. Lots of entities are appearing around. They are very similar ones to the other in some way. No?
That one is that was a paper that came from Japan, I think, wasn't it?
Yeah.
The mixed epithelial tumor with chordoid features. And I have to say, in the lesions that they describe, we have some examples of we don't get any brachyury expression. And that's what's so hard. Yes, we all read publications which have been submitted with the very best intentions, but probably 20 to 25% of the data that gets published turns out to be wrong in the end. Yeah. And it's very hard to tell.
Okay. Thank you very much. So I'm finished with the first case, and now I will stop to share the screen, and I will introduce the next speaker, who is María Carmen Gomez-Mateo from the Hospital Miquel Servet in Zaragoza. She is an expert on bone. She's the person on diagnosing bone and soft tissue tumors in the Hospital Miquel Servet. And well, she is a strong collaborator in the IMPERAS project and one of the persons in Spain who is fighting more for helping to improve the level of sarcoma diagnostic in Spain. And the time you have your turn, María Carmen.
Thank you, Cleo, for your nice introduction. Well, I'm not an expert. I'm trying to do the best of myself. Good afternoon to everybody, or good evening. Sorry, good afternoon. Good morning or good evening if you are following us around the world. My name is María Carmen Gomez, speaking from Zaragoza, Spain. I would like to thank Isidro Machado for organizing this virtual meeting, and also Cleo. And also I would like to thank Dr. Fletcher, Professor Fletcher, for sharing your experience with us. So let's move on to the second case, entitled Myxoid tumor. It was a lesion in the thigh of a 64-year-old woman of 4.5 centimeters that was surgically removed in June 2020 in another center. With the suspicion of myxoid liposarcoma, we were asked to perform a molecular study, especially DDIT3 fish. This is the panoramic view of the 3 different slides, where we can see this nodule well circumscribed of purple or bluish color, and also here some fat surrounding the lesion. Here, this is the background, the myxoid background, with a cell proliferation more or less uniform, round to spindle nuclei, and we can see here some monovacuolated cells and a delicate capillary network here highlighted with CD31. So here, could it be a myxoid liposarcoma? But here we can see some dark dots. We will come back to them later. Here we can see that this myxoid matrix became less prominent to this collagenous area. Here we can see this clear area corresponding to edema with some ectatic vessels with partially hyalinized walls, and also this Staghorn-like vessel, reminiscent to those vessels of solitary fibrous tumor. And here, this small area of ischemic necrosis. Also, we can see these eosinophilic collagen bundles, so-called ropey collagen, and some aggregates of lymphocytes. Here, if we took a closer look to the cells, they were more or less blunt, some of them with ovoid round nuclei, or stellate here, fusiform. And we can see also some bipolar eosinophilic cytoplasm and scattered monovacuolated cells. In other areas, the neoplasm became more hypercellular with spindle nuclei here, this elongated nucleus, or here angulated, and some multinucleated cells. Here we can see also these monovacuolated cells and these beautiful multinucleated cells, or floret-like, that we can see peripherally and radially hyperchromatic nuclei with a central eosinophilic cytoplasm, so-called flower petal arrangement, a very poetic term. But those cells were here a little bit ugly. We can say pleomorphic, with different size And here we can describe as monster cells. And there were some cells multi-vacuolated with indented nuclei that we could say pleomorphic lipoblast. So here, this is to show you three mitosis in a medium power field. The total count was 5 mitosis per 10 high power field, but I found this atypical horrible mitosis and another strange mitosis in another slide. So here I start thinking about a pleomorphic liposarcoma, perhaps. But here, if we focus on this area, we realize that this normal adipocytic tissue showed different size in the adipocytic cells. And here we have some hyperchromatic multinucleated cells intermingled with the adipocytic cells. And here it is just to show the difference in size. So will it be a dedifferentiated liposarcoma that this represents an area of well-differentiated lipo, and the other area is the dedifferentiated part with extensive myxoid change? So to this point, my differential diagnosis was myxoid liposarcoma versus pleomorphic liposarcoma and dedifferentiated liposarcoma. So Dr. Fletcher, Professor Fletcher, what do you think to these?
So I think even when the first images you were showing, there was too much nuclear atypia and hyperchromasia for myxoid liposarcoma, because as you know, they're cytologically often remarkably uniform, and you don't get bizarre atypical stromal cells and multinucleate cells in myxoid liposarcoma, at least only very, very, very rarely. So when you first started showing it, I thought it was going to be either pleomorphic or dedifferentiated liposarcoma. And then you showed us the atypical cells in the fat, so I'm sure it's dedifferentiated liposarcoma. But it's interesting because you have homologous lipoblastic differentiation in the dedifferentiated component. And that's the thing that is not so rare, and it makes a big difference, because if you mistakenly call dediff liposarc pleomorphic liposarc, the pleomorphic ones have a worse prognosis with a much higher rate of metastasis than the dedifferentiated ones. So it's important to be aware that you can get lipoblasts in the dedifferentiated component. So I bet it's MDM2 amplified.
Yes, thank you. So yes, because of the morphology, I rule out myxoid liposarcoma, and I was thinking between pleomorphic liposarcoma and dedifferentiated liposarcoma, but this area of well-differentiated liposarcoma make me think that it could be this diagnostic. So I asked for immunohistochemistry. CD34 was positive. Here we can see a tetrapolar mitosis and this pleomorphic cell. S100 was positive in those monovacuolated cells, and STAT6 and desmin were negative. A proliferation index was relatively low. And what about molecular biology? I performed DDIT3 FISH that was not negative, no translocation was identified, but also MDNT was not amplified. Here we can see more than 2 red and green signal consistent with polysomy, but it wasn't amplified. And I asked to another colleague to perform CDK4 that wasn't amplified. And also RB1 protein was lost in most of the tumor cells. So here, with the result of the immunohistochemistry and the molecular study, Professor Fletcher, what do you think?
I'm surprised, first of all.
Yes.
But I don't think the RB1 loss is relevant in this case because it doesn't fit so well with atypical spindle cell or atypical pleomorphic lipomatous tumor. The morphology is I mean, they typically have crazy looking multinucleate cells and crazy looking lipoblast, but they're not diffusely pleomorphic. And you can see RB1 loss even in D. diff liposarc and pleomorphic liposarc. So you have to be careful when you use that stain, which is also a difficult stain to interpret because more often than not, you have like half the cells positive and half the cells negative, and you don't know whether it's meaningful. I don't think you can persuade me that this is an atypical pleomorphic lipomatous tumor, but I think you're going to try to.
Yes, I want to try. It is true that I think that pleomorphic cells were so extent. I mean, perhaps because of my presentation that I made a lot of photographs of all pleomorphic cells that I found. I think that most of the tumor looks like a low-grade lesion. But I'm going to tell you one thing that I didn't tell you. The patient had a medical history. I just read it when I received the report, but I didn't pay attention to this and I forget. But when I have this problem with MDM2 negative and okay, I'm going to read more about the medical history of the patient. Here we have a prior surgery 20 years ago in the same location, and the diagnosis was intramuscular pleomorphic lipoma. And this woman consulted because she noticed a mass in the same location. And here we can see the MRI T1 sequence. And here this area that the radiologist...
Ya era un liposarcoma de bajo grado.
Sorry, there is something...
Quizá es diferencia.
Well, this area ill-defined that was thought to be fat atrophy or fibrosis, but the woman was monitored by MRIs, and this lesion had a progressive growth. But in 2020, the lesion suffered an accelerated growth, and here I can show you this MRI from 2020 with a fat saturation sequence where this lesion was hyperintense, which means liquid or myxoid. Here we have also these two images to compare. At the beginning, the lesion was white as the subcutaneous tissue, but here the lesion changed to a black color here. Okay, so I found the pathologist from the other hospital, and she kindly sent me the lesion of the 2000. And here we can see from the panoramic view this neoplasm, a deposited neoplasm infiltrating skeletal muscle. And here with high power field, we can see different size among adipocytes, and also these multi-nucleated cells here and here, some of them a little bit pleomorphic. So this is the summary of the case. We have the same morphology in this area now with the comparing to the old lesion, but we have a new nodule with extensive myxoid change and also mitosis and atypical mitosis. We have a long-standing growth for 5 years and with an accelerated growth the last month. So this is a late recurrence of this. So, Professor?
Okay, so you're torturing me, but I mean, I think under normal circumstances, if looking at the material from the year 2000, truthfully, that looks most like an atypical lipomatous tumor, you know, a well-diff liposarc in a surgically amenable location. And you can see, even on the screen now, the variation in adipocyte size and then those scattered atypical cells. So I would have guessed that it started out as a typical lipomatous tumor, and it would be interesting to know if there was MDM2 amplification in the 2000 specimen. I can only be honest. It looks like atypical lipomatous tumor that de-differentiated quite recently and turned into that ugly myxoid thing. But the molecular test you did not support that diagnosis. So I'm confused.
Me too. So here I changed my differential diagnosis and I included this one, this entity, this new entity. But it is true that I made this diagnosis. Probably, I don't know if it is good or not, but I made a comment because for me it was quite difficult to understand how a benign lesion, as supposed to be benign or low grade, can have this mitotic count and the presence of atypical mitosis. So I wasn't sure, and I recommend to close a close follow-up of the patient because I wasn't sure of this diagnosis.
Yeah, I mean, I don't think you should worry too much about atypical mitoses because, for example, if you see a mitosis in just an ordinary pleomorphic lipoma on somebody's neck, mitoses in pleomorphic lipoma are almost always atypical because they're crazy nuclei. And if you have a crazy nucleus, it can't make a normal mitotic figure. So I wouldn't worry so much about atypical mitotic figures per se. It's very, very confusing, strange case. I mean, I can't argue with your diagnosis because you've done all the tests, but in my heart, I still suspect that it's an atypical lipomatous tumor that's de-differentiated in a recurrent. But I'm just being completely honest because I find that the appearance is too extreme in terms of the solidly hypercellular pleomorphic things that you showed us, but maybe that was just, as you say, exaggerated by the images that you chose to take.
Yes, I think that if you see all the slides, probably there weren't so many. I mean, I just take a picture of any pleomorphic cell that I found. So I don't know if I had exaggerated this pleomorphism. I'm not sure.
Well, that's
so.
That's okay.
Okay, but just a comment. This entity was first named as spindle cell liposarcoma, but now this new entity is categorized as a typical spindle cell pleomorphic lipomatous tumor. And when I was preparing this session, I found this case report with atypical mitosis, and I felt happy because I think, okay, somebody found the same as me, I don't know. And I found also this paper from your group saying that atypical form could be seen.
Yes.
So
it's true.
So I don't know, it is true that I tried to, because my first idea was, okay, it is the differentiated liposarcoma, so MDN2 is going to be amplified. But when it was negative, I tried to, okay, CDK4, I'm going to try, but it was not amplified. So it was.
I understand.
So I don't know.
Keep your fingers crossed.
Yes, just to say one thing, the clinical follow-up, only 1 year. The lesion was re-excised because margins were positive and some foci of residual tumor was present in the sample. And at the beginning of the year, she had a MRI and CT scan negative. So just is the only thing that I can tell you because it's only 1 year of follow-up. Okay, thank you for your attention.
Okay, thank you very much, María Carmen and Chris. And now I will introduce Isidro Machado. Isidro is a bone and soft tissue pathologist of the Institute of the Oncologic Institute of Valencia. He's been working on sarcomas during the last years, well, lots of years, and he's been working also in research. He has done stages in other countries, in Japan, and he has a big net of contacts and is one of the person that has bring us today to here. Well, he's mainly the person. He has organized this session, so is also one of the biggest persons in the IMPERAS project, and is one of the persons who's working more hard to help Spanish pathologists to learn more about sarcoma and learn how other countries deal with sarcomas, or people from other countries deal with sarcomas. So Isidro, it's your turn. Thank you very much for everything and for your presentation now.
Okay, good afternoon. Thank you very much to all the attendees, and especially to Dr. Fletcher to be part of this second educational session. It is a quite honor for us. Just to remark that we are working always on a multidisciplinary team, that you know here, all the participants in this presentation. And our case hasn't any tricks. I only wanted to show you the many shapes, the many faces this tumor may have, especially when we are dealing with through-cut biopsy or core biopsy. So we have not any conflict of interest to disclose. So the case is was a 4-year-old male presenting with a 1-month history of progressive abdominal pain. A CT scan was performed. As you can see here, the CT scan showed a very large intra-abdominal tumor that revealed stem cell necrosis, and the tumor was partially attached to the small bowel wall. So also the CT scan revealed several liver metastases. A liver biopsy was performed, but unfortunately the tumor started bleeding and emergency surgery was performed due to hemoperitoneum. So as you can see here, this is the liver biopsy, the throughput, and the tumor showed maybe 2 different parts, paucicellular areas and more hypercellular areas, with a background highlighted by this branching blood vessel with a star horn appearance. Really, the tumor looks like low-grade tumor. There was some thrombotic blood vessel. As I wasn't able to find any mitosis or necrosis. There was no evident hyperchromatism or hyperchromasia, and the nucleoli wasn't conspicuous. You can see here the thrombotic vessel and the stack horn appearance of the tumor. So, sorry, but I wasn't able to get a microscopic picture from this tumor because it was very fragmented, that there was a lot of hemorrhages and necrosis. However, I was able to get a couple of imprints of the tumor. Curiously, the imprint reveal 2 different patterns like a biphasic tumor. In some way, the tumor revealed a low-grade morphology. However, in other side of the cytology, you may see here the hyperchromatic and pleomorphic. This looks like a karyotype, and this is a very pleomorphic. And of course, I was getting started to getting a little bit worried because this morphology didn't match with the liver biopsy morphology. So the tumor was removed, and you can see here the Nation-E histopathology. As you can see here, the tumor was attached to the small bowel wall, but not in direct contact with the muscular propria. The mainly grown pattern was patternless. The morphology, as you can see here, show a spindle and ovoid proliferation of tumor cell with, at least in these areas, a very low pleomorphism, intermixing with collagen stroma, and with this stem horn morphology, looks like the liver biopsy morphology. However, in other areas of the tumor, we saw and we found an abrupt transition between low-grade morphology and high-grade morphology, and the tumor looks like, at this point, like a Myxoid sarcoma. And in other fields, there was an abrupt transition between this patternless and round cells tumor that looks like, in some picture, like a round cell sarcoma or Ewing sarcoma. Really, I couldn't have thought in the final diagnosis of presumably this tumor, you will see later, with this morphology, I could have thought in Ewing sarcoma with this round cell morphology, but of course, there is evident two different patterns in this tumor. So I would like to highlight here that we have to be aware in core biopsy when we are dealing with this type of morphology in this tumor. So in other fields, there was only this transition between this patternless and the evident pleomorphic morphology with this hyperchromatic and very atypical mitosis that really match with the cytopathology that we have performed at the beginning of the study of the tumor. So at this point, I would like to ask to Dr. Fletcher for his opinion about this case, consider the clinical and radiological and histological feature.
Well, it's certainly a crazy looking tumor, but the material in the liver and the material in the sort of more orderly patternless component next to the bowel wall looks very good for solitary fibrous tumors. So I'm guessing this is dedifferentiated SFT with, and there would be obviously loss of CD34 in the DDIF component. But that would be what I suspect this is. It's a very dramatically ugly and morphologically heterogeneous one. And you're quite right about the problem with needle biopsies. They can make pathologists easily can look a fool interpreting needle biopsies, because when the resection comes and it shows something completely different, clinicians never understand how we can be so wrong. Yes, because they have no concept of the heterogeneity of some of the tumors. So I've grown accustomed to that now. I just suffer with a smile.
Okay. So jumping to the immunohistochemistry result, I would like to show you first the negative markers. So the tumor was negative for MDM2 and CDK4, as well as c-KIT and DOP. The epithelial marker were also negative. No expression of muscular marker, nor neural or melanic marker. Vascular were also negative, and neuroendocrine were also negative. So this is the immunohistochemistry for the liver biopsy. As you can see here, right, the CD34 was strongly and diffuse positive in the liver biopsy, as well as the CD99. As you can see here, highlighted the star horn pattern. But curiously, the Ki67 was unexpectedly higher, consider the blood morphology, at least of the liver biopsy. So I don't know if this represents the tumor progression, or this represents that this tumor has another non-sampling high-grade part that could be related with this higher Ki67. I don't know. So this is a speculation. So, and this is the immunohistochemistry of the tumor. So the presumably to a primary tumor, as well as in the liver biopsy, the tumor was strongly positive for CD99. That's what I say, that be aware with the round cell morphology, throughput biopsy, and strongly CD99 morphology. We may confuse with those type of tumor, but in this case, fortunately, the CD34 was also strongly positive. The cytokeratin was positive focally, and this may prompt us to consider includes another possibility like sarcomatoid carcinoma, or maybe somatic transformation in germ cell tumor, but this is unlikely in this case. Consider this pattern of biphasic tumor. Of course, we didn't see any gland formation or any epithelial component in this tumor. So MDM2 was negative as well as CDK4, but consider that we were dealing with a tumor where dedifferentiated liposarcoma could be a possible differential diagnosis. We would have to be sure that this tumor lacked an MDMD amplification, and we performed the FISH, and the FISH was negative. You can see here in different part of the tumor. So in the round cell component, in the spindle component, and the pleomorphic tumor didn't reveal MDM2 amplification. And the STAT6 show strongly diffuse and nuclear positivity, not only in the well-differentiated apparently area of this tumor, but also in the biphasic or dedifferentiated area, strongly positive in the spindle cell as well as in the pleomorphism. So at this point, I will for the second time to ask the opinion to Professor Fletcher, and also to ask a question. Should we submit this tumor with for additional molecular analysis to aid diagnosis and prognosis, consider the immunohistochemical profile, the clinical setting, and so on?
So, I mean, I think you very nicely proved the diagnosis of dedifferentiated solitary fibrous tumor, and all the evidence you presented is totally convincing. So you don't actually need any additional molecular testing. You could probably find some strange person who wanted to get, look for the fusion gene, the NAB2 STAT6, and I don't know of any molecular testing that would be prognostically helpful. So my answer to your question would be no, but on the other hand, it is very fashionable to use molecular testing liberally.
Okay, thank you. I agree with your answer. So this is so just to remark that this is a Mediterranean Sea coast. So I before presented the Nile Delta. So presumably the Nile Delta come to the Mediterranean Sea. So this is for relaxants in the section. So I just want to remark, yes, I entirely agree with your opinion, but maybe some emerges entity that may have a STAT6 overexpression, we may think in this case, but I don't think that this is a possibility, because maybe there is an oncogenic rich region that we know that there is so many genes, and presumably some case that have MDM2 amplification or GLI amplification or CDK4 may potentially reveal a STAT6 overexpression. So maybe the GLI1 neoplasm, the GLI1 neoplasm or GLI neoplasm with amplification could be the differential diagnosis, but I don't think this is that, because these neoplasms are more frequent in the head and neck. These neoplasms are usually CD34 negative, and as far as I know, there are no description of the differentiated GLI1 tumor. So as far as I know. So that is the evolution of the patient. Our patient was treated with pasopanib, and unfortunately, after 14 months of follow-up, the patient died of disease with a pathorenal syndrome. You may see here the extensive metastatic disease that was unfortunately. I would like to further discussion to make two other questions to Dr. Fletcher. Is a solitary fibrous tumor the ideal term for this neoplasm? I don't know. Solitary suggests that the tumor can be cured with surgical resection alone and wouldn't require any special clinical follow-up for surgeons, I mean. However, we have recently another case of a 53-year-old male with a tumor very similar. So in some way similar, was a periprostatic tumor, and the tumor was removed, and the appearance of the tumor was very blunt. So I could never say this could be malignant. The STAT6 was positive, the gene fusion was positive. The tumor prospectively did not reveal XTR mutation, neither P53 wild type, and the tumor was classified at low risk by the MICO system. However, after 26 months of follow-up, my oncologist, that luckily is my friend, Dr. Javier Lavenia, came to my office and asked me, Isidro, are you sure that this is solitary fibrous tumor? This is really solitary with this very large metastatic disease in the lung. So to be honest, I didn't know what to say at this moment. I was a little embarrassed, but I say, maybe a burning issue is how to predict the potential malignant behavior of this tumor in not of frankly worrisome histological sign. And that is my last question for Dr. Fletcher. Thank you.
Okay, well, so, I mean, of course, solitary fibrous tumor is not a very good name. It's because there are so many fibroblastic lesions that are solitary. I mean, you could use it to describe many things. The problem with changing nomenclature is it ends up confusing people, both pathologists and clinicians, and it's very hard to change nomenclature. I mean, there are people who would say we should call it, spindle cell neoplasm with NAB2 STAT6 gene fusion, and we begin to sound like hematopathologists. Nomenclature is a big problem because of just like even getting rid of MFH was problematic because people just didn't understand where the hell it had gone. There is no question that morphologically, even totally benign looking SFTs with no mitoses at all, very occasionally metastasize, which is why Liz D'Amico developed this risk assessment system. And the low risk ones, as you know, usually the risk of metastasis is approaches 0 in the first 10 years of follow-up. But I certainly have cases in my file of things that would be classified as low risk that metastasized. So the name is not ideal, but we have to acknowledge that we cannot always reliably predict the behavior of solitary fibrous tumor. We know for sure that some of the really low risk looking lesions do behave aggressively, but we cannot predict it at the present time.
Okay, thank you.
Okay, thank you very much for the presentations. Now we have time for the discussion and for questions. There's no any question in the chat at the moment. If someone wants to participate actively, just open the camera and the microphone. I don't know if Enrique or Professor Llombard or Empar, that I've seen that they are around. If someone wants to say something, please, you are welcome.
Good afternoon for me in Spain. Welcome to all people. This is a great pleasure to be here today. I want to congratulate all the three speakers. I have nothing to say to add. Maybe the differentiated liposarcoma is a case which I will agree with Fletcher, and diagnosing as a differentiated liposarcoma. The cases of Cleofé are fantastic, are very nice, and I have enjoyed it very much too. And the case of Isidro, I know it very well because we have been working together. This is a difficult situation to speak about solitary fibrous tumor without metastasis. That is a tricky situation, no, Christoph?
Yeah, of course. And clinicians are so literal. I mean, none of us would think of solitary as meaning non-metastasizing.
Yeah.
I mean,
Yes, that is the case.
That's the point.
It's very hard to educate clinicians. We have to do, and it's getting harder because there's less and less pathology in medical school curriculum around the world, and so they understand even less of what we're talking about. It's kind of scary.
Yes, it's a difficult situation. Yes. What do you mean, Enrique?
No, well, I wanted to comment on the prognosis of SFTs and on the molecular stuff. Of course, I agree with Chris that we don't really need molecular stuff to make a diagnostic workup of SFTs, but having, I am a little bit fan of molecular. Having done NGS of about 100 of SFT cases from clinical trials, I have to say that there is a correlation between the type of transcript, truncated transcripts. Some types of transcripts are related to a poor prognosis, and we are also studying the expression of telomerase components, TERT, P16 mutations, and we are about to submit a manuscript on that. In that, regardless of some morphological, very benign and quiet morphological features, you may have some worrisome, let's say, molecular facts that are linked to a worse prognosis. So I think, of course, we don't need any molecular for diagnosis, but maybe there are some prognostic hints beyond morphology that we can maybe study. So maybe this is research, but maybe in the future we will use it for prognosis.
I mean, that's fascinating. I'm sure that will be a great paper when you publish it, because we haven't sequenced as many SFTs as that, because everything in America is all about money and people have to pay for sequencing. And
Yeah.
actually our sarcoma clinicians are using sequencing less and less and less, because in sarcoma as a whole, it's not usually very helpful. I mean, it hasn't added a lot. And so we sequenced, I think, 2,000 consecutive sarcoma cases that came through the clinic, and I mean, all we found were things like KIT mutations in the gist, that kind of thing, nothing terribly exciting. But it sounds like you have interesting data. The problem it brings is the vast majority of pathologists around the world don't have access to NGS, yes? So they won't be able to use it in real life.
Yeah, that's why. Yeah, that's why. In Spain, within IMPERAS, we try to have a centralized second review system to make sure that every rare case is at least seen by a sarcoma pathologist, and extremely rare things can be sequenced if needed. And of course, we don't need to sequence 95% of sarcomas, but maybe there's a 5% set that, of course, is useful, especially for round cell things, and some Myxoid things as well are useful. So where there's a hype, and then there's, of course, a correct indication after the years in which maybe this happens, like in EM, for example. We don't do any longer any EM, but maybe we won't do any longer any NGS, so maybe just for some particular cases. So maybe we'll find out.
I mean, the other thing is too that you may find things by sequencing that then allow the development of biomarkers that can be used.
Yeah.
Yes.
Much easier.
The prognosis and therapeutical implication also for that.
Exactly.
Yeah, thank you. We have one question now. It's from Xavier San Juan from the Hospital de Belvitge in Barcelona, in Hospitalet, that is a city close to Barcelona. He's asking, is it possible to have well-differentiated or dedifferentiated lipos without MDM2 amplification?
So the official answer is no, because it's definitional, yes? But of course, we all know, especially those of us that see lots of sarcomas, there are plenty of tumors that break the rules, yeah? And there's always surprises. I mean, I would suggest to Maria, maybe you should try doing MDM2 FISH on the 2000 lesion and see if it was amplified then, but who knows? I mean,
yes, I was thinking, because I don't remember if I test MDM2 in the previous lesion, but I'm going to do it. Yes, of course. And I was looking for the number or the percentage of liposarcoma without MDM2 amplification, and the only that I read was that almost all are amplified with MDM2, and 94–96% with CDK4. So yes, probably there are some cases with negative MDM2, but
yeah, I had one case. years ago with without MDM2 amplification, but with CDK4 amplification, and also DDAT3 amplification that is also in the same region. So I was convinced in this case, but without anything. So she did DDAT3 and it was not really amplified. No, we had only 2 or 3 signals per cell. CDK4 was not amplified, and MDM2, it's really difficult to consider that.
Well, also the genetics become part of the definition, yes, for so many tumors.
Yes.
I mean, for example, we know that we can't find, you know, SSX, SS18, you know, rearrangements in all synovial sarcomas, even when they're typical. There's 3 or 4% that don't have it, and they probably have alternative gene fusions. But certainly MDM2 amplification has become definitional for well-diff and D-diff liposarcoma.
But perhaps I remember sometimes hearing to Angelo Paolo de Tos, that I know you, all of you know him, that I think that he accepts some cases of well-differentiated liposarcomas with MDM2 amplification. I think just I think that I hear him sometimes saying something like this.
I mean, the problem is things like atypical pleomorphic lipomatous tumor were probably all called liposarcoma before the entity was, you know, with David Creighton's published his series and so on. So there's always this constant evolution. It's what makes the job interesting, but it makes it harder.
Si alguien quiere hacer una pregunta en castellano, sin problema, ¿eh? Lo podemos traducir.
Well, perhaps I wanted just to make a comment about solitary fibrous tumor. That's a very nice case you presented, Isidro. And I remember a case I had several years ago here in Belviche, that I have a multiple solitary fibrous tumor as multiple nodules in the peritoneum. It was a young woman in her 30s, I think, that has 8 or 9 nodules in the peritoneum after giving a child. And they was, all of them, typical solitary fibrous tumor, but the only thing is that it were multiple nodules. It was really unusual.
This situation is quite similar to occur to granular cell tumor, that you don't know is this multiple or is I don't know the opinion of Dr. Fletcher. This multiple.
Yeah, I mean, it's impossible to know, isn't it? Because obviously you would suspect if somebody had multiple nodules of solitary fibrous tumor that these must be peritoneal metastases from one of the lesions. And the only way you could verify that would be to sequence them all and see if they had exactly the same fusion in each one. But it's, I mean, there are so many strange things that we all see occasionally and we cannot explain. And then you have to try and get clinicians to understand there is no explanation.
I have also a question regarding Marie Carmen case, the adipocytic tumor. You have much more experience than me in this atypical spindle or atypical pleomorphic lipomatous tumor. Is it frequent to have all these difference in adipocytic size in this tumor also, or is more typical from the classical well-differentiated lipocyte?
No, you can have quite a bit of variation in adipocyte size, especially in the atypical pleomorphic lipomatous tumor. Okay. Not so much in the atypical spindle cell one, but the pleomorphic ones, the crazy thing is they actually look more pleomorphic and more bizarre than either pleomorphic lipoma or conventional atypical lipomatous tumor. So in conventional atypical lipomatous tumor, most cases you don't see dozens and dozens of crazy cells, you just see scattered ugly cells, yes? And you don't see dozens and dozens of pleomorphic lipoblasts in atypical lipomatous tumor, but you do in atypical pleomorphic lipomatous tumor, and it's completely paradoxical in the way we look at things.
Okay.
I think there is a question.
There's another question for Isidro. Selene is asking, which was the proliferative index in your case?
This is hard to answer because it was very heterogeneous. So in the low-grade component was very low, but in the differentiated area was very high. So there was very heterogeneous Ki67 proliferation. But as you can see in the liver biopsy was higher than expected for this morphology, at least in the liver.
And that is part of the problem with the heterogeneity of lesions and when you have only the biopsy. Okay. I don't know if someone of you wants to, there are no more questions at the moment. If someone wants another question, please go ahead. And if not, if some of you want to say something, comment something, no? No? Everything is okay. So I think we are finishing our meeting. It was really a pleasure to share this time with all of you. And we are really grateful with Professor Chris Fletcher because we know you are a busy person and we are very happy to have you here today. All of you are invited to follow our following sessions that we will have one per month, but this month, because it's the Sarcoma Awareness Month, we will do another session next week with Dr. Uta Fluke, Dr. Eva Bartelman, Dr. Rita Lagio, and Dr. Carlos Monteagudo. So all of you are invited next Thursday at 4:30 in the same link. And just, if you want to say, just finish the session and thank you very much once more to all of you and see you next Thursday.
Thank you very much.
Thank you.
Thank you.
Thanks, all of you.
So,
Bye.
bye.
Bye, Chris.
Bye.
Bye.
Bye. Nice to see you.
Nice.
Thank you very much.
Okay.
Nice to see you, Chris.
Bueno, hemos sobrevivido. La
Vale.
gente reacciona poco.
Enhorabuena a todas, y todos.
Bueno, ha estado muy bien, ¿eh?